much again for joining us again for Monday night's travel chat. This is Elizabeth, one of the travel team nurses here at CNY Fertility. I'm one of the nurses on the global travel team, and the Monday night travel chats are dedicated all to just bringing more information to help you understand what the process is going to be once you begin working with the global travel team. So we know that it's such a stressful process to undergo fertility treatment in and of itself, but to add traveling on top of that really does add a level of complexity to the situation that then adds stress. And so I started doing these just as a way of hoping to give more information to then decrease overall stress levels. I know that one of the biggest things that people come here for in terms of the chats are to get some of their questions answered. So every month or so, I like to dedicate a whole night's show, if you will, to just answering questions, because I know a lot of times I will get going on a topic and then we won't get a chance to answer your questions. And so tonight we're just going to dedicate it to answering all of your questions, and I'll fill in the blanks if there aren't a lot of questions with some sort of frequently asked questions. Rebecca, you are welcome. It is our pleasure. Rebecca says thank you for all you and your team do. We're so lucky to get to do what we do, and we are so very lucky to be a part of your journey and to walk along this path with you, because we know it's definitely not an easy one. And so we're all here, all the nurses here on the travel team, all of the teams here at CNY Fertility, we're all here to make your journey of getting from point A to being pregnant and delivering your baby a real reality for you. So we're very excited to be a part of your journey. Nicole says, shout out to Nurse Alicia and Dr. Chang. Today traveled our 4-hour, I think she says 2-3-day embryos in Buffalo. Well, that's amazing, Nicole. And my prayers and all my positivity are headed your direction for a wonderful, wonderful outcome here. So that's just amazing to hear. And we're so excited. Lots of thank yous and lots of you people really grateful. And we really appreciate that. And really appreciate all of your positive stories. So yes, Nicole, sorry, I kind of butchered through that, but I figured out what you meant. But congratulations in advance. Totally hoping and praying for a wonderful, wonderful outcome. So like I said, tonight, we're going to talk primarily just question and answer time, so that we can just, like I said, minimize stress levels and get some of your frequently asked questions answered. So I will start with the first question, which was, how is Gonal-F used in an FET? This is a really good question, Amanda. We get this question a lot, and Gonal-F is not routinely used during a transfer. But if your FET protocol involves Gonal-F, then what you're doing is what we would call a modified natural FET, where the natural part is a little bit deceiving, because we hear natural and we think that means no medications. And what a natural cycle really means is that we're using your body's own natural ovulation to time the transfer, for one, but also to support the pregnancy. So in a spontaneous conception, where you don't need our help to get pregnant, which would be the dream for everyone, but in a spontaneous pregnancy, your body actually knows exactly what hormones that pregnancy needs to thrive and be ongoing. And the two primary hormones are going to be estrogen and progesterone. And in a medicated cycle, because you did not ovulate and aren't able to create or supply your own estrogen and progesterone from within, that's why a lot of protocols involve supplementing estrogen and progesterone from the outside in the form of pills or tablets or injections. In a natural transfer, or a modified natural is what we would call using Gonal-F, we're actually using that Gonal-F to stimulate the ovaries to develop a nice healthy follicle so that we can trigger it and have it be the source of estrogen and progesterone that support the pregnancy. So in a Gonal-F FET, you would begin you would begin the Gonalef shots usually towards the beginning of the cycle. We would develop a nice healthy follicle. And then once that follicle was of an adequate size where we know if we trigger it, it will be able to supply the necessary estrogen and progesterone that the pregnancy needs, then we instruct you to take that trigger shot. And then we time your own natural ovulation. That becomes the guideline or the marker for when we actually do the transfer. So for example, if we trigger you today on a Monday and you have blast embryos, what we typically do is a trigger shot on a Monday. You would start any external progesterone support on a Wednesday, and then you would transfer the following Monday. So for the most part, on a triggered FET, you would trigger and then 1 week later would be the embryo transfer. So I hope that helps. The Neupogen, that will be incorporated in the beginning of the cycle, and as will the Gonalef. But you very well, Amanda, you may have estrogen and progesterone, and it's good to have those even in a modified natural cycle, because there are times where we do need to still supplement with one, the other, or both. And so having them on hand could be a really big help. So, but that is what Gonalef is used for in an FET. Okay, so Stephanie says, will an in-person consult be required after the initial phone consultation for travel patients? No, absolutely not. So we understand that traveling to us for anything is a big undertaking. And so no, your phone consultation that you have scheduled for August 30th is your new patient consultation. And what will happen after that is once you're finished speaking with the provider, that provider will send a task or a message over to the global travel team, identifying that you are a new patient and you need to kind of get into the rotation. And so what we do then is within about 2 weeks, sometimes we're a little less, sometimes it's a little bit more, but within around 2 weeks from your new patient consultation, a nurse from our team will actually reach out to you and sort of give you all of your onboarding steps or help you kind of understand what all of your next steps are going to be. And that's done through a phone consultation as well, where a nurse will reach out to you. But your in-person requirements sort of start when we need you for an egg retrieval. So your kind of first chance to meet all of us face-to-face in the Colorado office, and I'm not in the Colorado office, I'm from the travel team, but your opportunity to sort of meet in person will be at your egg retrieval. And our team, the travel team, will help you with everything and anything you need from the time that we first call you 2 weeks or so after your new patient consultation. From that point forward until you step foot into one of our offices, our travel team will take very good care of you. So that's a great question, but no in-person consultation is required. So that's always a good thing to hear. Okay, let's see here. Oh, hold on a second. I got myself all the way to the bottom. I'd like to go in order on the questions here. Okay. Alexandra is asking an excellent question, and I will preface this by saying I cannot tell you the answer. This would have been a wonderful question for 2 weeks ago or 3 weeks ago when we had our embryology team on. But she's asking why pronuclei aren't seen on day one. 5 eggs, 3 degenerated, 2 cleave, but they didn't see pronuclei. That is such a good question, and I will never pretend to know the answer if I do not. Please send a message through the patient portal to the embryology office where you had your eggs retrieved, and they would be able to explain the answer to that, or give you the answer to that, because I would not even stretch to be able to explain that one to you. Okay. Lisa, this is a good question and one that gets asked a lot. We do throw a lot of vaginal medications at our clients for supporting the pregnancy, and we know that those can sometimes lead to a yeast infection. I don't know of an instance where a yeast infection has really affected anything after transfer, as long as we get it treated and it doesn't get out of control. So it is a common thing that happens just because of the amount of vaginal medications. And so it happens, but don't let it worry you that it's going to wreck your transfer, because it's not. Alethea, I hope I didn't say that wrong, but it probably did, is asking what labs are required before your next period if you're just getting started. So Alethea, again, probably butchered that, but I would say if you're just starting with us, the biggest thing we request that you do, it's not required, but it is highly recommended, is to complete all of the preconception testing that is in the patient portal for you. So part of the new patient consultation and the follow-up that happens 2 weeks later from our team is that we will usually within about 24 to 48 hours of your consultation, we will upload orders for you to have those preconception lab testing items completed. And those give us a good overall picture of your health and your readiness for pregnancy. And what I mean by that is, for example, one of the tests that we recommend as a part of the preconception panel is to make sure that you're immune to some common childhood diseases like varicella. And so what happens if you're not immune? We're going to recommend that you be vaccinated against that disease so as to not create issues in the pregnancy. And so we don't want to find those things out when we're not able to really do anything about it. So there's really the short answer to your question is no labs are required, so to speak, but there are some labs that are recommended prior to your baseline when you're ready to actually get started with treatment. And those are what we call the preconception lab. So if you have had a new patient consultation more than a couple days ago and you do not have that lab order for the preconception testing in your patient portal, send a message over to the global travel team and we will be more than happy to make sure that that gets uploaded for you. All right. So next question is from Amber, who asks, if you do a short cycle of birth control for 2 weeks, does it usually make you start a new cycle after stopping? The answer to that question is yes. Typically, any more than 7 to 10 days of birth control is going to kind of reset the body, and by stopping it will cause a withdrawal bleed. So while you don't start a new cycle, so to speak, you will oftentimes get a bleed. So I think the answer to that question is probably a yes. So anything less than 10 days may or may not cause a bleed. And it also does depend on what your lining thickness is when you start the birth control. Because if your lining is very, very thin, then stopping it might not be enough to cause you to bleed. So that's a good question. Another question here from Ashley. What paperwork do I need to have completed before my retrieval? There are a lot of packets. Ashley, you are right. Haven't heard anything from financial, so do I need to call them? Okay, so let's start at the beginning. What paperwork do you need to have completed before your egg retrieval? The big ones that we request that you have completed as soon as possible are, there is a paper in, I believe it's the Global Travel Consent packet. We tried to consolidate everything that needed you to fill out something and reply into that consents packet. And that could have changed recently, but I do believe it's in the consent packet. There is a sheet that says Global Travel Client Agreement, I believe is what it says. And there's a place there for you to let us know who your monitoring facility is. That, and then there's one set of consent forms that is for an IVF and any subsequent transfers. It's a 7-page document. We do have to have all 7 pages of that document back, and all of them have to be notated. Everything has to be completed. So that 7-page IVF or transfer consent, the Global Travel Client Agreement, and then there is a page in there that says accept decline, and that's your opportunity to tell us which of the recommended preconception testing items are you willing to do, or do you want to decline? So those are the biggest 3 things that we like to have done before the egg retrieval. But most importantly is the consent form. So we wouldn't be able to proceed with a surgical procedure in the office, obviously, without a consent form. So that's the only one that's truly required. But you really do yourself a disservice by not completing everything, just because I find that the more we can each communicate with each other, between you as the client and us as the office, the better the cycle turns out. So the number one thing back is the retrieval consent. And then as for financial, they are getting to our clients just as fast as possible. But if you have not heard from them yet, you are always more than welcome to reach out over the phone or send a message through the patient portal, and they'll be able to get you the information that you need. So that's a great question. Thank you so much. Lauren's next question is the Georgia location going to be doing retrievals and transfers soon? Well, Lauren, I hope to not further any miscommunication or confusion. My understanding is not in the next 6 months. So that may be something on the horizon, but our next up and coming full service IVF and full service location is going to be in Florida. And so to my knowledge, not in the next 6 months. Again, there's always things that pop up, that crop up that I don't know about, but as far as I know, not in the next 6 months is that on the horizon. Okay, so Elena, I'm not sure if I'm saying that correctly either, but is asking if I can help clarify stim and retrieval versus transfer. Hopefully I don't completely misread your question, but so typically there is kind of two portions of the process, the leading up to and the egg retrieval itself. So we call that stimulation and retrieval. And then after retrieval is either fresh transfer and subsequent monitoring or a frozen transfer. So for retrieval, you'll usually call at the beginning of your cycle. We will send you for a baseline somewhere between cycle days 2 and 5. And then you'll receive a call as soon as your results are received and reviewed, and we'll let you know everything to start for the stimulation phase of the process. That phase of the process typically lasts for about 10 days, with the egg retrieval happening somewhere around the 12th to 14th day. Egg retrievals can happen as close to maybe 8-10 days after the stimulation starts. So everybody's body really does respond differently. And that's why we're so not trying to be difficult, but we get asked all the time, when will my retrieval be? When will my retrieval be? And oftentimes, until we know, we just don't know. And so that can present a lot of frustration with scheduling travel, time off work, things like that. And we know it really is tough. But it is something where we do need to do frequent monitoring to make sure that we trigger you at the appropriate time. And so that could be anywhere, like I said, 7-8 days into stimulation, all the way 13-14 days into stimulation. But what happens once it is determined that you're ready for trigger? You'll be given a trigger time sometime in the evening between 9 p.m. and sometimes as late as 2 or 3 o'clock in the morning. Usually not 3 o'clock, but sometimes as late as 1 or 2 o'clock in the morning. And then 35 hours from that designated trigger shot is when your egg retrieval will be. And when you are ready for trigger, you will receive a call with all of the trigger instructions, telling you exactly how to do the trigger, when to do it, where to do it, the written instructions, the video instructions. We really do try to give you everything we possibly can to ensure that you've got it down pat. And then the transfer portion. So after the egg retrieval, you will, if you desire a fresh transfer and we determine that it's safe to do one, then we will give you instructions for the transfer, which usually will take place 3 to 5 days after the retrieval. But if for any reason you're not doing a fresh transfer, either you're doing genetic testing and we know we're going to need to wait on those results, or if there's any reason you don't want to do a fresh transfer, or sometimes it becomes a matter of safety if we do a fresh transfer. And what I mean by that is the process of ovarian stimulation, or what we call controlled ovarian hyperstimulation, which is the process of stimulating the ovaries with the stimulation injections, can create a situation where your ovaries get very, very enlarged, secrete a lot of estrogen, and can put you at high risk for ovarian hyperstimulation syndrome. So ovarian hyperstimulation syndrome is something that does not occur until after the egg retrieval. So you cannot have, quote, OHSS. The syndrome, which is the collection of symptoms, starts typically 3 to 5 days after egg retrieval, and is typically a result of fluid leaking out of the ovaries and filling the belly and other areas of the abdomen with fluid that's not supposed to be there. And so if we tell you that a fresh transfer is not safe, the reason for that is because what is the hormone we all test for when we're trying to get pregnant? That hormone is HCG. Well, it just so happens that HCG kind of helps to fuel all of that fluid that's leaking out of the ovaries into places it doesn't belong. That is exacerbated or increased heavily as a result of any HCG. So let's say you have HCG that you were expecting to trigger with, and we couldn't trigger with it. For that same reason, we wouldn't want to introduce a pregnancy into the body, because that pregnancy is going to secrete HCG, thus flaring the ovaries and really sending OHSS out of control. So transfer will take place, like I said, if fresh is appropriate and desired, 3 to 5 days after retrieval. Whereas if a fresh is indicated either because you want or because we recommend, that that frozen transfer rather is typically done around a month, 3 to 4 weeks from the retrieval. So after the retrieval, usually 10 to 14 days, you'll get your menstrual cycle again. You'll call the office with cycle day 1. We'll send you for a new set of baseline, so an ultrasound and set of labs, and then we'll give you a new set of medication instructions to begin to help thicken that uterine lining, so that around a week later, when we send you back, that ultrasound shows us that yes, indeed, your lining thickened, looks great, and then we time your progesterone starting according to when your transfer is, so that your embryo has the exact amount of progesterone that it is expecting. So very long-winded answer, but hopefully that helps kind of understand the timeline between stimulation, retrieval, and transfer. Okay. Nikki is saying, I've heard there's not a lot of direction when doing the medication protocol, and people have not recommended doing CNY as a first-time IVFer. What support is there for first-timers? There's a huge learning curve with injections. Yes. Well, I'm very sorry to hear that anybody would not recommend coming here because as a first-timer, just because we really do our very best to be inclusive and helpful to all. However, with your question, it can be intimidating, but we do like to give you all of the tools at our disposal to help make that process easier. So in addition to written instructions that will literally show you day by day exactly which medications to start, when to start them, how much of them to give, etc. We also will have on our website, you can find video injection teaching lessons that walk you through start to finish exactly how to give each and every single injection. And then also we work with the 2 biggest pharmacies that we typically tend to work with. Each have their own dedicated nurse concierge, if you will, who will be happy to FaceTime with you, have a phone conversation with you to help make sure that you do understand how to give the medications. So we will support you. We have thousands and thousands of first-time IVF clients with us that start and have successful cycles every single year. And if you find that you need more direction or more clarification, always ask. But we really do try to give you all of the instructions in written form. We go over it verbally with you at each time a nurse reaches out to you and chats with you. And then we also try to provide that video teaching to help reinforce and make sure that you've got it down pat. But if ever you don't, like I said, most of the pharmacies even have a nurse that will FaceTime you and go over everything with it so that you can make sure that you've got it down pat. So hopefully that helps. Mimi is asking, starting stim day 1 tonight. That's so exciting. Do I continue taking Claritin, Benadryl, Pepcid? I've been taking these for priming. Yes, that's completely fine. The Claritin, Benadryl, Pepcid are part of the antihistamine protocol. They are all over the counter, so no harm in continuing those. Absolutely. All right. So Christy is asking, had my baselines today, was expecting to start stimulation today, cycle day 4, but they're having me start Wednesday, cycle day 6. Any reason for a later start? Any concerns? Great question. And I'm so glad you asked it because it's a question that we get daily, weekly, all the time. We get this question. So there's really not a problem starting later in the cycle. You can really truly start stimulation even as late as after you ovulate. There are follicles that are there and ready to be grown and triggered and retrieved. So the reason I would say that you're given a cycle day 6 stimulation start is primarily to do with safety in the offices. So we really do take safety as an utmost concern, and we want to make sure that we have the adequate staff, supplies, procedure time, etc. We want to have all of that available for you when the time comes. And so we do stagger our starts out. And we see very good similar outcomes between those who are starting earlier, those who are starting later. So no concerns at all about starting cycle day 6. You'll do great. But that is that's primarily the reason why you were given that stimulation start. And again, because we can't predict when everybody's periods will start, we really do our very best at having an open schedule that it can accommodate you whenever you call. But sometimes that means it might be a day or two off of what you were expecting. But we always have your safety and your overall success as our primary outcome or our primary goal. So hopefully that helps answer your question. All right. So Nicole is asking, starting HCG boosters tonight. Excellent. Does this med continue to 12 weeks? I believe it's 10 or 12 weeks. Offhand, I'm not sure which, but we will absolutely give you instructions when it's time for you to be transitioned or discharged to your local OB. We will give you instructions at that time for exactly when to discontinue those medications. So that's a great question. And congratulations on getting to the point of starting boosters. That's awesome. All right. Ebony is asking, how soon after laparoscopy can you transfer embryos? Typically with the next menstrual period, unless the doctor who performed the laparoscopy has different post-procedure instructions, the typical is as soon as that next period comes around. All right. Erica's question is, after egg retrieval, when are normal embryology updates given? And that's a great question. So you'll usually get a call with your fertilization results the day after the retrieval. And then usually you will not get an embryology update until the cycle is complete. So once the cycle is complete and your embryos have all either been frozen, transferred, whatever the case may be, that's the point at which you're going to usually hear from our embryology team. So like I said, you'll usually hear from the nursing staff the day after the retrieval, so we can get you your fertilization report. And then probably not again until your cryo report or like I said, that there's been a disposition of all of your embryos. So hopefully that helps. Okay. Kayla, that's such a hard question to answer. So 5-week ultrasound beta was 6,722. Progesterone dropped a little. So progesterone ebbs and flows, as does estrogen. That's very normal. Why your embryo is measuring 5 weeks, 4 days at your 5-week ultrasound. I might be curious about your dates. Usually we don't send you for an ultrasound before 5 weeks, 4, 5 weeks, 5 dates. So 5 weeks, 4, 5 weeks, 5 days. Why is that measuring off? I'm not entirely sure. I would be more curious if maybe the pregnancy dates are a little off. But ultimately, early obstetrical ultrasound has a window of about plus or minus 5 days. So it's not uncommon for the embryo to measure a little bit differently than the weeks and days of pregnancy you are, based on when your transfer is. So if you had a 3-day embryo transfer, you could consider yourself 2 weeks, 3 days along at transfer. Whereas if you transferred a blast embryo, you could consider yourself 2 weeks and 5 days along. So perhaps look at that again with your transfer dates. And then if you are in fact just 5 weeks, but measuring a little bit ahead, just know that you're well within that window margin of error for early obstetrical ultrasound. No worries whatsoever. Okay. Tara, this is a great question. Thank you so much for asking it. So Tara's asking, what are the requirements to do a fresh transfer? So the requirements are typically the following. The first is we want to see that at your IVF baseline, so the baseline ultrasound that you went for when you got started with stimulation, we'd like to see that your lining is less than 7 millimeters, which is a good indication that the lining that was there the previous cycle, in that cycle that did not result in implantation, we want to make sure that that lining goes away, bleeds off the way it's supposed to, and that you're starting with a nice thin lining, so we know that everything that's built up is fresh, nutrient dense, and ready to support a pregnancy. So first thing is we do like the baseline the baseline endometrial lining to be less than 7. The second is if at any time, not necessarily if at any time, so nearing retrieval or at retrieval, if your progesterone is elevated, that's going to be a good indication for a frozen transfer. So it's an embryo expects there to be a very finite amount of progesterone in the body at the transfer. Because, like I said before, in a spontaneous conception, the body knows when to supply these things. And so an embryo has an expectation that there be, like I said, a finite number or finite amount of progesterone in the body, typically in a number of hours. So, for example, a 5-day embryo expects there to be about, or a blast embryo is more correct. So a blast embryo expects there to be around 120 hours of progesterone. And so if there are 130 hours or 120 hours, that can tell the embryo that there's something wrong and that do not move forward with implantation. So if during your stimulation cycle, your progesterone goes up for any reason, that might be a time where we say, we don't recommend a fresh transfer. So let's go ahead with a frozen. So that typically looks like any progesterone above 2 at retrieval typically would necessitate a frozen transfer. So that would be, I suppose you could say, a requirement is a progesterone less than 2. And then also, estrogen. So estrogen levels anywhere above 3,000, you're going to be expecting a conversation with the provider between 3 and 4,000. I have seen fresh transfers be permitted up to about 3,500, sometimes a little more, a little less. I think it's really important to point out at this stage that just because it's appropriate for someone else doesn't necessarily mean it would be appropriate for you. So there's a lot of different considerations to take into account. So, for example, if your estrogen was only 2,800, but you weren't allowed to do a fresh transfer, that could be because your AMH is much higher. Or let's say you used a medication called letrozole, which suppresses the estrogen. And that would be a case where if you and I both went through with a retrieval, and on day of retrieval, or let's say on day of trigger, my estrogen was 2,800 and yours was 3,800, but I used letrozole and you didn't, that could cause a difference in which one of us is maybe going to be recommended a fresh transfer versus which might be recommended a frozen. So I know that's kind of roundabout, but I think it is important to note that those requirements are not necessarily across the board, just because there are nuances to each of them. But high estrogen at retrieval, progesterone over 2, or a lining that's too thin. So maybe you get to your retrieval and your lining's only 6 millimeters. That's probably going to be another time where we say might not be in your best interest to do a fresh transfer. So I hope that helped kind of narrow that down for you. Okay. So Amanda is asking, what happens if I'm flying in, I take all of my medications as prescribed and my flight gets delayed? Amanda, I'm not sure if you're talking about retrieval or transfer. Retrieval is pretty darn specific to the trigger time. So if you're talking about your retrieval portion, you took all of your medications, you triggered, and you're looking to get here and your flight gets delayed, that's certainly going to be a concern because those eggs are only going to be available for a very small amount of time. We will always recommend that you fly in and arrive the night before. And that typically helps to mitigate against any delayed flights or things like that, because as long as you get here the day before, that gives you kind of all day the day before to handle any delays or things like that. Because yes, in let's say an absolute worst case scenario, you triggered and you can't get to us on time, that could mean a situation where the eggs that we grew and we triggered are now not available for the retrieval. So with that said, it is very important to have a backup plan. I always tell the story when I get asked a question similar to this of a wonderful client I had once upon a time. This was years ago, who triggered, it was in the winter time, and flight was delayed. So it was a layover in Chicago, and then she wasn't going to be able to get to the clinic, ended up driving through the night to get to the clinic for the retrieval. So there's always things that we can do. But I suppose, yes, and as an absolute worst case scenario, if you were to be, coming for retrieval and not able to get here on time, then yes, that would be something where if the eggs were not available at the retrieval or when you did get here and we could always help you with that timeline, then yeah, you would essentially have to start over. But it's a great question to ask because it really highlights the importance of really having a backup to the backup. So knowing that if you're flying to our offices in New York from California, and obviously there's going to be certain circumstances that there's no planning that would, solve the situation. But having a backup plan, making sure you're coming in, your flight comes in with ample time before your retrieval or your transfer. Those are things that can all help make sure that that doesn't become sort of a life-altering, issue for you. So, okay. Next question from Sarah. Some scarring seen at the top of your uterus during a saline sonogram. Can they do surgery to remove that at the same time as the egg retrieval? Not typically. It certainly depends on what exactly was seen, but usually the most that we do in terms of surgically during an egg retrieval would be a hysteroscopy, where a camera is placed inside the uterus to look around and evaluate the position of things like fibroids or scarring, things like that. But usually surgically, the only thing that we will do at the egg retrieval itself is remove something like a polyp. So not knowing exactly what was seen, we certainly could do a hysteroscopy at your egg retrieval, but whether or not that specific spot could be treated, that's a different story. So definitely feel free to ask that question through the patient portal, just not knowing exactly what was seen there. But if it was truly scarring in the uterus, that's not something that we would be able to surgically sort of repair in a retrieval type of environment. So, all right, excellent. Next question. This is a good question. So Jamie says PCOS on metformin, all your tests came back good, no blockages, all good. That's amazing. That's a great first start. First round of IUI in July, any tips? I would say that the biggest tips are to make sure you are well organized now. So if you're beginning that first round of IUI in July, just making sure that you do in fact have all of your medications, that you have a plan for your sperm source the day of the IUI. And if you're not using a partner sperm, that you have frozen sperm in the office, just really planning ahead. Those are the number one things that I see derail cycles are, sort of a lack of planning and or just sort of not realizing what the timeline is. So sometimes I will call a client and let her know that she's ready to trigger for an IUI, and she'll be sort of surprised thinking it was going to be a lot later. So I think just jotting down a list of questions that you can have answered at your baseline phone call. So once you call with cycle day 1 in July, we give you an order and tell you what day to go for your baselines. You're going to get a call once those results are received and reviewed. And it's during that call would be a great idea to just ask the question, approximately when do you anticipate the IUI being? While we can't tell you down to a couple of necessarily a day or two, we can oftentimes estimate within a window of 3 to 5 days. And so just asking those questions ahead of time, just to make sure you have a good understanding of what to expect, when that IUI might be, those are all things that I find just the organization seems to really help. And then the only other thing I would say is just have a good backup to your monitoring facility. So it doesn't happen super often, but it does happen where monitoring facilities, especially if you're using your OBGYN's office, maybe the provider had to leave the office to go to the hospital to take care of a patient, with something imminent. So it's always good, I find, and we get it. Not everybody even has one good location to go to, let alone a backup. But where you can, just really, truly planning ahead, having good, solid expectations of the timeline, the medications, and making sure you have all of those things in order prior to your period starting, those will really help you get off on the right foot. So hopefully that was a good answer for you. I got this question a little earlier. Oh, I think I answered this. Lauren was asking about Atlanta. Like I said, I'll reiterate, it's most likely not going to be in the next 6 months. Things do change, but I wouldn't anticipate it being sooner than 6 months. Carla is asking a question that we do get a fair amount of time regarding visas, and would CNY give relevant documentation to give proof of treatment? Absolutely. So depending on what specifically you need, we're absolutely able to write a letter that supports or gives weight to the fact that you are seeking treatment in the United States. And so typically that is sufficient, but you would need to definitely work with your local embassy and the United States Department of State to determine what specifically is needed, so that we could give that letter and make sure it has its entirety, in its entirety, exactly what would be needed to support your claim to come here for medical treatment. But as far as writing a letter and giving that documentation, that shouldn't be a problem. So, okay. Next question is, what day do we start ganirelix or cetrotide? So that's an excellent question. We typically will start it somewhere between stimulation day 5, 6, or 7. Occasionally usually it started day 6. So 5 to 7 is a pretty good window. Definitely check your patient portal. We most often request that all of our clients have 6 doses of either the ganirelix or the cetrotide. 6 is the most common dosage or the common quantity needed. So check your patient portal. If we ordered 5, send a message to the travel portal and or the travel, to the global travel team. We can take a look and see if we think 5 would be appropriate in your situation, or if we think that it would be better and best to have 6 on hand. So one of the number one things that can kind of change the plan in terms of retrieval and the process itself is if you need cetrotide and you don't have it, that really kind of pigeonholes us into a specific plan. So let's say, for example, that we really thought it would be best to trigger you tomorrow, but you took your last dose of cetrotide today, then we're going to need to trigger you today, because otherwise you risk ovulating and losing everything. So for what it is worth, my recommendation is always to have an extra cetrotide as opposed to one too few, because that one extra, yes, it would potentially be some wasted money in the end, but it would be a lot more wasted time, energy, money, etc., if you needed an extra one and couldn't get your hands on one. So I would say double check in your patient portal under medications to see what the quantity ordered was. Double check through your shipment from the pharmacy to make sure that you really don't have 6. And then if you truly have 5 and 5 is all we order, just check in through the patient portal and we could take a look and make sure that 5 will be appropriate for you. But that's an excellent question and really brings me to a good point that I hadn't had a chance to mention really tonight, but a little bit, which is that you are being so prepared. And I really appreciate that, because making these discoveries now versus when you need that extra cetrotide and you can't get it, now's the time to make that discovery. So really just looking through, inventorying everything you have, making sure that what we ordered was what you got, that you're not running one too few or whatever the case may be. But those things are best figured out now rather than once you're under, you're just under the time pressure of needing to have it right now. So, okay. So let's see here. Candy is asking, PCOS was on Clomid for 3 months, started at a 0.1 and only went to a 0.5. What would you recommend I do? Candy, I am assuming you are talking, I'm not sure what lab value you're talking about. The only one that rings a bell would be AMH, but I would be surprised with PCOS if your AMH was super low. So definitely feel free to ask that question a little later. The only lab value that comes to mind on the fly here is that your AMH. And if it really was 0.1 and went up to 0.5, that's a pretty good response. But again, I'd be a little surprised with PCOS if it was that low, but certainly each person is their own biology and things surprise me every day. So if you're talking about AMH, that's a pretty nice response in 3 months' time. If you were talking about something different, then feel free to sort of clarify in a second. Okay, let's see here. Next question. Ashley is saying, the cycle I want to do in August, my predicted period is estimated to start towards the end of a 4-day trip. Yeah, if you have 2 cycles coming before then, if birth control is appropriate for your specific situation, and it's not for everybody, but that's something I would definitely message those dates into the patient portal, and we can do our best to try to estimate where we think everything will fall and if birth control might be a good plan, because that is a really good option for some people to time out their cycle to work around life. Yeah. So next question is from Lauren. She says, are they not doing them? Is that why you skipped the question? I didn't, I didn't, I don't believe I skipped any question on purpose here, but I know you asked about Atlanta location retrievals and transfers. So yeah, I think the answer is still the same, which is there is not a plan that I'm aware of. There is not a plan to have Atlanta be a full service IVF center in the next 6 months. There certainly could be a plan that I'm not aware of, but I am not aware, like I said previously when I answered this question, is that our next full service location is slated to be in Sarasota, Florida. And so, like I said, to my knowledge, there's not a plan to do retrievals and transfers in Atlanta in the next 6 months. So hopefully that helps. Let's see here. Amber is asking, we have a lot of Ambers who joined us tonight. Ambers and Ashleys. I love it. Are there any tests not done by CNY that my husband or I will need before our consultation so that we may move on as quickly as possible? We plan to travel to Colorado from Oklahoma and do local monitoring. I cannot think of a procedure or test that would be recommended for you to move forward that one of our offices does not complete. Obviously, each patient has his or her own kind of story and pathway, and so I suppose there could be something in there, but as a general rule, no. The majority of our clients do all of their testing. Their testing is all done locally before they even come to one of our offices. So I cannot imagine what that would be if it was anything. The only thing I could say is if your husband needs any type of surgical sperm procedure, that's something that has to be set up ahead of time if you're coming to Colorado, but certainly something we can do in Colorado. But I cannot think of at the moment, any testing that would need to be done that we don't do. So hopefully that helps. All right. So Brittany is asking or stating, so supposed to transfer at the end of the month, tested positive for natural killer cells, waiting on the additional labs to come back, started antihistamines, going to do intralipids, but I'm beyond nervous, don't have any chances. I can 100% empathize with that. And just for what it is worth, Brittany, the intralipids is the answer to elevated natural killer cell activity. So, if you were just beyond concerned that the intralipids wouldn't be enough, you could always do several doses of intralipids and have your natural killer cell activity tested afterwards to see if that number changes. That would be something you definitely want to discuss with a provider. But the answer to elevated natural killer cells is intralipids. And so I know it can be really unnerving and anxiety provoking to have something that diminishes your chances. But with that said, knowing that intralipids is the appropriate response to elevated natural killer cells, hopefully that will give you some peace of mind with moving forward. Next question from Nicole: is bleeding a little right after the transfer very typical? Didn't have that. Very, very little irritated cervix. Yes, 100%. If there was one little tiny thing I could whisper in everyone's ear at transfer and moving forward is, just because you bleed, that does not mean it's over. And I know I have been a fertility patient myself. I have had bleeding in early pregnancy myself, and I know that feeling of, oh my gosh, it's over, and it's not. So your cervix is very vascular, and when you pump your body full of hormones, it becomes even more so. So yes, even bumping into the cervix with the speculum as we visualize the cervix and pass the transfer catheter, that in and of itself can cause some bleeding. But early bleeding in early pregnancy, as long as it's not excessive, it's not causing pain, it's not more bleeding than you would expect in a typical menstrual cycle, Anything more than that is definitely worrisome, and we definitely want you to get checked out. But spotting, light bleeding, those things are very expected after transfer and should not worry you at all. So hopefully that puts your mind at ease, because it is so common, and it is, while it's terrifying, it is really common. So, okay. Oh, Talisha, this is such a great question. And I wish if I could ever come up with an answer to this, I would be a very popular fertility nurse. But there really aren't any good indications that the transfer has or has not worked before you take your first beta. I wish there were. It's such a painful 10-day wait that, we truly do wish there was some other way that we could know. But even things like tender breasts, nausea, those things can come with the territory without a pregnancy being successful. And so there really are not any good indications that a transfer was successful prior to the first beta. I guess unless you were to get your beta drawn early and it was positive, but other than that, and that is highly discouraged just because it can really confuse the picture. But no, there's not any really good indications before the beta. So like I said, I wish I could think of one. Okay, next question from Karina is, been taking Omnitrope for 6 units for 29 days, tomorrow's cycle day 1. No. So we highly recommend, unless your treatment plan is any different, like I always say on these live videos, what I say is more general advice. So in your given situation, it could be a little different. And just quick tangent before I answer your question, Karina, I think that's really, really important to note, because oftentimes we will hear clients say, oh, I'm getting conflicting information or conflicting advice. And that's not necessarily the case. Oftentimes, just because another client had what we think looks like the same exact situation and did something different, doesn't necessarily mean the answer was wrong. But in your case, unless your treatment plan dictates differently, we highly recommend that you continue Omnitrope all the way through the retrieval, or to the retrieval, usually through to the trigger, because we know that Omnitrope is highly effective at improving egg quality and oftentimes even helping with the maturation process, making sure that that egg enters its final maturing phase before it's retrieved, because an immature egg will not and cannot fertilize. So like I said, unless your treatment plan is something vastly different, as a general rule, Omnitrope is continued and recommended to be taken through the trigger itself. Okay, next question. Lining too thick for transfer last time in today's cycle day 2. Anything I could do to help thin it? No, not really. Hopefully that won't be the case. If when you go for baseline this time, there's really nothing physically that you can do in terms of over the counter or supplements or things like that you can do to thin your lining out. So fingers crossed that it is thin enough to start this time, because like I said, there's really nothing you can do on your own to thin it out. So, all right, next question from Jamie is, can you do back-to-back IUIs same month, 24 hours apart? Absolutely. We do see a fair number of clients that request the back-to-back IUIs, so 24 hours apart. So basically you would trigger, let's say you trigger tonight, we'd have you come in for an IUI tomorrow, Tuesday, and Wednesday. So 100%, if that's something that you'd like to do, definitely make sure that your nurse is aware that that's a part of your plan, and we can definitely make that happen. Lauren, yes, absolutely. Is there a way to take birth control in order to have more control over when the retrieval happens? Yes, there is. Still, though, we can usually narrow it down with the birth control within about a week. But if your dates are 2 or 3 days kind of restricted, even birth control could make a situation where it doesn't fall the days you hope it will. But if you're trying to get it to fall within like a 2-week window or a 1 week, even maybe a 1-week window, birth control would be an excellent option just to help kind of pigeonhole the treatment window into a specific time frame. So yes, and as I've said before, birth control is not indicated for everybody, not safe for everybody, but if in your situation that's something we can do, then that definitely can be a way to make sure your transfer or your retrieval, happens within a certain time frame. Amy is asking, any way naturally besides medication to thicken lining for those of us with thin lining? Not anything that's really well documented and well researched. There's a lot of sort of anecdotal homeopathic things out there, pomegranate juice, things like that. The one, and I have no doubt I'm probably going to get a lot of commentary and potentially some phone calls about this, but one thing that, I have heard, again, anecdotally, I haven't heard that there's any research to support it, but physiologically makes sense, is orgasm leading up to your lining check. So we know that orgasm causes the sort of the uterus to contract, increase blood flow to the pelvis, and some of the medication things that we use if we do have lining thickness stubbornness. So if you're known to have a thin lining, sometimes what we use to thicken it up is Viagra, and Viagra is intended to dilate the blood vessels and increase blood flow to the uterus. And so, theoretically, orgasm could help do the same thing. So again, that's anecdotal. I am not aware of any firm research in that department, though it could be out there. But that is one thing I hear a lot from clients, that their lining was being very stubborn. They tried it and it helped. So, but besides medication, that's the only one I can think of off the top of my head that could help with lining thickness. All right, lots of excitement. So that's excited. People excited for their cycle. So that's amazing. Let's see here. Maria's asking, cycle was canceled last month, 220, and period is delayed. That could be potentially, I don't know why your cycle was canceled and at what stage your cycle was canceled, but if your period is delayed, you can absolutely call the office or send a message through the patient portal and request that we upload what we call no menses diagnostic order. So basically, my period didn't come on time and I would like to know why. You can go in for an ultrasound and a set of labs, and oftentimes that can help us determine maybe a period's not forthcoming and everything indicates you're good to start meds now. That's possible. And it is oftentimes possible to start medications, at least for an IVF, a retrieval stimulation cycle, is oftentimes appropriate to start without a period. And so I would say if it's late, then please request a requisition to go get it checked out to see maybe why that's happening, and we'll make sure we get you those orders. Done. Help. I can't get a hold of anyone in the office. I'm so sorry. Forgot to put a diagnostic code on your baseline orders. Well, Don, I will be happy to take care of that for you when I get back to my desk after this live video. But because I am somewhat absent-minded, I am going to, hopefully you are under the same first and last name as you sent here, but I will fix those orders for you as soon as I finish this show. Okay. I'm so sorry about that. But I will make sure that those get fixed for you. All right. Lauren, another question from Lauren. And I just got my email from myself, Dawn. So you're set there. Can a husband provide a sample before retrieval, have it frozen? Absolutely. So as long as your husband has pretty normal sperm parameters, we can absolutely freeze a sample in the office. And if he doesn't have normal sperm and you have any concerns about whether or not that would be adequate, we can certainly look at that before the time comes. But many of our patients find that it's just too stressful. There's too much up in the air to have their partner come to the retrieval. While we do say a fresh sample is best, we do lots and lots and lots of successful cycles with frozen sperm. And so if that's a real obstacle for you, definitely inquire through the patient portal to see if that's something that we can help with. Glenda is saying, message multiple people in the travel and prescription team. Hopefully you were helping me out with Dawn's concern. But if anyone else had something urgent for this evening, definitely let me know and I can make that possible for you. Lauren's asking, how do you know if you need priming? That is something that's determined by the provider in your new patient consultation. Next question. Glenda looks like she helped answer this for someone who's Neupogen. Yeah, so that looks to be answered. That's awesome. Thank you again, Glenda. We already answered that question. Pretty much, I think we answered that question. Talisha is asking if you do sorry, I lost it. I think your question was, if your transfer is unsuccessful, when can you try again? usually with your next period. So I'm guessing by your 2 questions that you're in your kind of 10-day wait. Girl, keep the faith. Please keep the faith. Don't cancel, don't make your transfer, or don't count your transfer out as unsuccessful before it has a chance. You've got this down pat. It's never bad to have a backup plan in terms of, well, what could I do differently if this doesn't help? But ultimately, please keep the faith, because you got this. You got this. All right. We have time for like one more question. And I apologize if I skipped several in the process of kind of jumping all around here. Let's see here. One last question. Bear with me here. Okay, this is a pretty good question, but definitely something I can answer in the last 2 minutes here. Retrieval on Wednesday, when would you expect the FET process to start? So for all of those others whose questions I didn't get to, I do apologize. We had an hour and we definitely used it all. But Amanda, in terms of last question here, I would expect the FET process to start in about 2 weeks. So retrieval was last Wednesday. You'll probably get a period, usually 10 or so days, 10 to 14 days from the retrieval. So I would expect a period, maybe not this Wednesday, but maybe next weekend or the early days of the following week. And then the FET itself is usually about 2 weeks from the baseline. So sometime around cycle day 14-ish. Can't say for sure, but I would say if you just had your retrieval last Wednesday, you're probably looking at a transfer in the next 4 weeks-ish. So again, these timelines are always very kind of out there in terms of they don't apply to everybody, but that's my best guess. I know I said that was the last question, but this is a good question and a question we get a lot. Can I do an IUI on my own, or is this doctor recommendations only? So Faria, we're very open to whatever type of treatment plan you want to do. So let's say and I'm not entirely sure that I'm answering this correctly, but if you mean do an IUI at home on your own, that's not typically something we do that I'm aware of. An IUI is typically done in the office by one of the providers. But if you're asking, could you choose to do an IUI on your own if the doctor doesn't recommend it? You absolutely could do that. So again, IUIs are performed in a medical office. The sperm typically has to be prepared and put into the uterus in a certain fashion. So usually not at home. But if that's something that you would like to do, let's say the doctor recommends IVF and you're thinking more along, maybe I want to try IUI first. That's definitely something that we could do. So, all right, that is it for us tonight. I truly appreciate you all giving me, the opportunity to answer your questions. Again, if I didn't answer any of your questions and they're urgent, call the office. If they can wait till tomorrow, you can absolutely send them through the patient portal. And then Dawn, I got your back. If you give me about 10 minutes, I will make sure that your orders are fixed so that they have the diagnosis code. I do hope everyone has a wonderful evening, and we'll see you again next week, same time, same place. And I hope everyone has a good week. Bye-bye.